name is Bob Yang, urology consultant at Royal Berkshire Hospital in Reading and a clinical lead for the functional urology department. It really is my pleasure to talk to you about a new approach we have been using in our patients for overactive bladders to deliver Botox to the bladder in the outpatient setting using the new leaner Med Operascope. So I think we all know about incontinence. I think we all know the overactive bladder is defined by the ICS as urgency with or without urgent incontinence. And actually, usually with frequency not sure. And actually, currently the first line treatment involves, conservative management, medications, oral antimuscarinics, beta-3 agonists, etc. But many patients we know cannot tolerate these oral therapies, and actually their symptoms are not sufficiently controlled. And that's the result. Botox has really come in and shown to be very effective in managing these patients with refractory OAB, saving them from progressing to more invasive procedures such as SNS or even the clam cystoplasty, where often they need a week or so staying in hospital. Now, Botox for OAB is currently recommended as first line, both in the UK by NICE, but also in Europe by the EAU. And in fact, the IMBARK study, as we all know, which was a landmark study that showed the efficacy of 100 units Botox in IDOs, or idiopathic diffuser overactivity. Now, traditionally, in the IMBARK study and in history, the Botox was delivered under general anesthetic as a day case by both urologists, but also urogynecologists. And 100 units is diluted in 10 mils of saline and injected via 0.5 mil blebs around the bladder. And you can imagine, actually, with the current waiting times and actually increasing frailty of patients, as well as anesthetic burden, doing repeated general anesthetic procedures is just not a sustainable option. So in recent years, there's been a massive push and move away from the general anesthetic to the local anesthetic session, and importantly, performing in the outpatient setting as it's more relaxed, more desirable for patients in the repeated GAs. But actually, it's more significant also in the cost effectiveness, that keeping in mind that patients, often have to have repeated injections. It's definitely a lot more cost effective. Typically, every 9 months, patient with IDO will have to have another top up for the Botox. And also what other people have done as well is actually decrease the number of injections. So instead of doing 20, people now do between 5 to 10. And actually studies have shown in the last few years that actually by doing fewer injections, you decrease the post-operative pain by actually 30% compared to the original method from the IMBARK study. And more recently in times, people have now started using adjuncts like lidocaine installations prior to the procedure and also the weird and wonderful stuff. But quite frankly, it doesn't actually work very well. There was actually no significant difference compared to just using urethral Instillagel alone. So in spite of all these benefits, there's still quite a lot of issues with the current outpatient setup. Even if you use reusable scopes, in the outpatient, if you use reusable scopes, you need sterilization facilities. These can often break down. These can often have problems. The turnaround for the scopes can be slow. And actually, for private practice, most importantly, actually, you've got to ensure the site you're working at has all the necessary equipment, screens, stacks to deliver this procedure. And for the procedure itself, actually, when we use the flexible scope, it's a two-handed procedure. You've got one to control the scope, one to hold the end because it's quite long. And actually, then you rely on someone else to deliver the Botox for you. And that person can't just be any standard assistant. It has to be someone qualified, a qualified healthcare professional who's licensed to deliver medication, which obviously limits what we can do. So this is really where the leaner Operascope came in. And notice our gynecologists using this sort of all-in-one semi-rigid scope with a built-in screen for their hysteroscopy. So we thought, look, instead of letting the gynecologists have all the fun, which is not great, we should bring it to urology and actually have some fun ourselves. But most importantly, obviously, to improve the service for delivering Botox in our patients. As in particular, it is licensed for use in the bladder. So the key here is this scopes allow the procedures to be done on any standard outpatient couch in a more comfortable supine position. You do not need for them to be in stirrups and a lithotomy position. And importantly, because it's a scope that you can hold with one hand, it keeps the other hand free so that you can inject the Botox yourself, and therefore it's an all-in-one. You don't have to rely on anyone else or a trained healthcare professional. So actually the easier thing to do actually is to show you a video of how we do it. So next, what we're going to do is show you a video to show the setup and how we deliver Botox using this new Operascope. So over to you, Michael. We are delivering this in the outpatient setting. It's a nice, relatively short video which shows both the technique, the setup, and how it actually works. So if you just give us a few moments, it'll be hopefully available shortly. Leaner Operascope. Here you can see the one-time use disposable scope, which comes with a built-in twistable screen. Here we show the setup for delivering Botox in the outpatient setting on a sterile field. Here we show the setup for delivering Botox in the outpatient setting. On a sterile field, we have the disposable scope and battery pack. The Botox has been drawn up and diluted in 10 ml of sodium chloride and mounted onto a needle ready for use. An instiller gel allows for the local anesthetic and is simple to prep the patient. The patient is undressed from the waist downwards and covered with a gown for modesty. They are then asked to lie down supine on a standard outpatient couch. This technique removes the need for stirrups and the lithotomy position. The scope has a gentle deflection at the tip, which is positioned upwards to facilitate insertion into the urethra. Here you can see the working channel and how the needle exits the tip of the scope. The working channel is built within the handle of the scope itself and is located within the dial which controls the deflection of the tip. Upon entering the bladder, both ureteric orifices are identified and the bladder is inspected. In order to better facilitate patient tolerance, 5 2 ml Botox injections are performed transverse in the bladder, avoiding the trigone. The Botox needle is then inserted up to the marker, ensuring the bevel Botox needle is then inserted. Holding the scope in one hand and the Botox syringe in the other, 2 ml of Botox is then injected into the bladder, ensuring a good submucosal bleb with each injection. As you can see, unlike traditional methods which require 2 people, one to inject and one to do the scope, our technique allows easy Botox injection using only one healthcare professional to do both at the same time. Importantly, this technique gives the operator total control of the Botox injection itself. After the last injection, the needle is made safe by sheathing within the working channel and the whole scope is then withdrawn. A 10 injection technique is also doable with the Operascope, again transverse in the bladder. This time only 1 ml is pushed per injection, again in the submucosal region.
Finally, even when the urine is unexpectedly cloudy, most bladder can still be inspected for a diagnostic cystoscopy. Only the dome and the J maneuver is not possible. The Operascope still provides good views of the bladder mucosa, and the bladder aspiration can then be performed via the port at the base of the handle to remove the debris and provide a sample for MCNS testing.
Excellent. Thank you very much, Michael, for that. So as you can see, really, it's a very neat little scope, actually. With a diameter of less than 12 French and a single working channel with a screen that can basically rotate towards me. The two patients we saw, in fact, the three patients were all done awake in the outpatient setting, just lying flat on a standard couch. And you can see how easy it is to actually deliver Botox in that setting without the need for lithotomy and actually getting quite good transverse coverage of the bladder, both from the 5 and the 10 injection technique. And most importantly, you control the injections. You don't have anyone else to do it for you. And so actually, people can inject exactly how much they want, and no one's going to accidentally inject the whole syringe, which has happened before, in some centers where your assistant gets a bit keen and bang, slaps in all 10 mils in one go. So, you have a lot more control then. And actually, you can see in the last clip as well, if the urine is unexpectedly cloudy, again, attaching a syringe to the other port, which you can see in the top right-hand corner, that allows you to aspirate the bladder, suck out all the debris, get rid of it, and also send it for microscopy. And it gives you good views for the rest of the bladder, especially the dependent area, just to make sure there's no significant debris left and get rid of any stones as well. So I think the key thing is, from this technique, what are outcomes like? So in the last couple of years, we've used the scope to deliver Botox on a whole range of patients, and we've audited our outcomes in the first 50 cases. So these were all cases done with a leaner Operascope using a standard Instillagel on an outpatient couch. And what we did was, we've had 50 women with urodynamic confirmed OAB. Well, most of them were urodynamic confirmed, and they were all refractive to the standard medical management under aseptic conditions with Instillagel. So the usual stuff. We diluted the Botox in 10 mils of saline and gave them between 5 to 10 injections, as we showed in the video, in the clamp cystoplasty line. The dosages were between 100 to 300 units, and you can imagine most of them had the 100 units one. This is a quick rundown of what we did, and you can see the key here is actually you just really need two staff. One HCA, which is not medically trained, just to help clean up and set up equipment, and that leaves the operator to focus simply on the clinical aspects of the job, as opposed to having to worry about anything else going on as well. So the very easy setup for this. So all 50 women successfully completed the procedure, which is great. You can see from the average age, actually, we had quite a good range from the 34 to all the way up to an 88-year-old patient. So 15% to 30% of our patients in this cohort were actually deemed elderly. And within that, over half of them were actually deemed frail on the PRISMA score, so i.e. 7 or above. So these are the patients who generally are not suitable for anesthetics or even repeated anesthetics. And actually, these are the patients which often are not even offered therapies because of their overall frailty. A lot of our patients were comorbid as well, and actually we had quite a few obese patients, which, as you know, in any situation makes whatever operation we do slightly more difficult, but even that was doable. The results were actually very, very promising. So you can see here the average pain for Botox, as reported by the patient, on average was 2.2 out of 10. So this is on a visual analog score we got them to mark. And as you can see here, 2.2 out of 10, which is very, very good. Interestingly, the pain, when we did break it down, was mainly when the Botox was injected. It wasn't actually when the scope went in or when we looked around. So actually, that's why I think, obviously, when we limit the number of injections to less than 20, it really does help with the tolerability. But furthermore, quite uniquely, what we did was assess how much this pain compared to their previous smear test, which is something almost all women in the UK have had, and previously, provides a very good, relatable benchmark for women to counsel patients on this procedure to have it done under local anesthetic instead of fully asleep. And what's great, as you can see here, is that most of them, in fact, all the vast majority of the patients, on average, found the smear test to be a lot more painful than the Botox injection, 3.6 out of 10. And if we would then break it down further, if we look at the overall two groups, there was a statistical difference in the two groups. In fact, the elderly group in general found the whole procedure to be a lot more tolerable than the younger group. So again, don't forget, these are the elderly patients who often we don't treat because actually they're a bit too frail and often can be put to the side, or even GPs don't even refer to us. For Botox, where the pain was 2 versus 2.3, and the smear test actually 2.9 versus 3.9. Fantastic. So actually, even for the elderly patients, don't hold back. Actually, this is something that we can very much offer patients of all ages and all comorbidities. And so you can see here, overall, there was certainly a statistical significant difference in pain levels comparing the past smear test to the Botox with the Operascope. In terms of complications, of course, we did have some complications. We had one screen distortion, so the screen itself wasn't very clear. A few digital lines going across it, but still the vision was good enough for us to deliver the procedure. It's a very straightforward procedure that I think everyone can be quite quickly taught how to do. And in terms of UTIs, we had 2 cases with 4%, both treated with oral antibiotics. But importantly here, that actually we quote 16% in our literature for post-op UTIs. So we actually had a very low number in comparison. And importantly, no cases of urinary retention in any of this cohort either. Now, looking at this further, nothing in life now comes without money and funds. So actually, if you were to do a business case for this, especially on the NHS, the key here is the 2 procedure codes, the LB14Z and M49.4. This is more for the UK audience and our international audience. But in terms of cost breakdown, which obviously does apply for other countries as well, we get the same tariff, we get the same money from the central pot, either to be done as a general anesthetic outpatient day case procedure or an outpatient procedure. Hence why it's so much better to do it in outpatient, because you can see here it's 1.5K to do it under general anesthetic. But if we move it down to an outpatient with the Operascope, you can see the tariff is actually more than covers the actual cost of the entire procedure itself, including the other associated costs. And I think the final thing I want to say here this evening is actually nothing now comes without the environmental impact. I think we are now more and more aware that is important in business case and decision making. Initially, there was a lot of skepticism regarding single-use disposable scopes, especially from a study in 2022 where it showed there was a lot more CO2 when it comes to disposable scopes in terms of how much versus how many cases. But in recent years, we've realized actually it's not just about CO2 in manufacturing. It's about other factors, wastewater, mineral consumption for manufacturing, ecotoxicity. And so studies have now shown that in terms of when we look at the entire picture, water for sterilization, the waste products from the sterilization itself, actually a disposable scope comes out better than reusable scopes with actually less impact on the environment, which is actually very, very reassuring. So that's everything from me. I hope that was helpful, and thank you very, very much for your time. And I really do welcome any questions you may have. So just 1 second, Andre, if you turn your microphone on. This is just like in COVID times when we first started using Teams, isn't it? And we had lots and lots of little technical issues. That's right. Was Andrew trying to sort out her microphone? I think what I'll just say is, before she looks at the questions, actually, one thing we didn't mention in the video is actually this hysteroscope, this Operascope, I've actually used for other procedures as well. So it's not just for delivering Botox. I know we have an audience of urologists and urogynecologists tonight. We've actually done quite a lot of cases for using this Operascope for stress incontinence as well. So we've done it in combination with, deflux, Bulkamid, etc. And it actually works very, very well. Now, obviously, you do have to inject. some local anesthetics around the urethra for that. But we've actually used it in quite a few cases to do local anesthetic urethral bulking in the outpatient setting. So actually a very, very tolerable procedure. So Andrew's back.
Yeah, so that was one of the questions actually. If you use this device for stress urinary incontinence. So I suppose you do.
Yes, absolutely, and very easy to do. Because it's shorter, it's not like the long cystoscope, you have much better control, and actually it's quite straightforward. It's a little bit more fiddly, obviously, compared to the Botox, because it's a very small operating area, but certainly we've done it a few times, and there's not been any problems.
Yep. And then we have a set of 3 excellent questions. So what needle did you use for the Botox procedures? Can you mix both toxin with lignocaine, and can other toxins be used?
Yeah, so in terms of other toxins, you can use, Dysport, you can use the new Illusians for in terms of help decreasing the overactivity symptoms, whatever you have in your local hospital. In terms of needles-wise, currently we use a variety. We either use the Inject needle, which is the one from Labary, but the one I prefer to use is actually the deflux needle, the metal one, because it's solid and it's short and it's exactly the length of the cystoscope, the Operascope. So, it really helps me inject it, and it's just like doing a Botox injection and a general anesthetic because it's rigid, very, very easy to control without actually having the patient asleep.
Thank you very much, Dr. Young. Okay, so we have another question. Is it possible in the same procedure, the same time, to perform the Botox procedure followed by an exploration of the endometrium with the same Operascope? I'm not sure.
I'm not sure about that one. As a urologist, I try to avoid going to that area of the world where it seems to be a bit more dodgy compared to my safe zone on the bladder. But what I would say, however, is for patients with overactivity bladder, sometimes they get a combination of overactivity and stress incontinence. And we have done many cases where we do B&B, Botox and bulking together. And this is a lovely case where you can actually, through the same scope, obviously different needles, please do change the needles between them. We can do both bulking and Botox together. Whether you want to stuff the same scope up in the endometrium, I'll leave that for the gynecologist to answer.
And we can definitely consult with the gynecologist who uses this and get back as the person that asked this question. So we'll get back to you, do not worry. Okay, so another question. What is the recurrence rate for overactive bladder post the Botox treatment?
Yeah, so in general, using this technique, even though we decrease down to 5 and 10 injections, our recurrence rate is exactly the same as when we used to do 20. So it generally lasts anything between 9 to 12 months. And as you well know, people who do it a lot, is that actually as the efficacy period drops, and especially when it drops below 6 months or 4 months, we can then start upping the doses. So we haven't seen much decrease at all comparing this technique versus our previous technique. So yeah, the usual 9 to 12 months is what we quote patients.
And then we have another good question. So do you use any other type of analgesia apart from the Instilogel?
So this is very interesting. We haven't needed to at all. So there has been literature published where people use, lidocaine in the bladder for 20 minutes beforehand, before doing the procedure. We just literally use Instilogel first, give it a minute, and then scope goes in and perform the procedure. I think, honestly, the pain a patient is just from the injection site itself. You decrease that, you have a sharp needle that is small, and you do the procedure quickly and efficiently. Actually, it is very, very tolerable. You don't need any other adjunct. And so I think we haven't had to use any other adjuncts either.
Thank you very much, Dr. Young. And also, do you fill the bladder before the Botox injections?
Yeah, so with any cystoscopy, what you do is you get the patient to void first. So you start with an empty bladder, put the scope in, and you can see in the video, the bladder slowly fills up while you're filling through the scope. And as you're filling, you're doing a diagnostic cystoscopy, getting things ready. And then whilst it's relatively full, you then perform the Botox injection.
Okay. And thank you very much, Dr. Young. And we have a very good question from a gynecologist. Okay, so maybe this is for when we bring this up with the gynecology surgeon. Oh, no, sorry, my bad, 2 separate questions. So have you done any autologous fat injections at the internal meatus with the Operascope?
No, that's not something we do. In fact, that's more because that's not something we routinely do in the UK. In the UK, very much for the bulking procedures that we do, we generally use a bulking sort of procedure, either with deflux or bulkmid. I suppose anything else, if they still fail that, we'll then go down the autologous sling route or the copal suspension route, depending if they have bladder descent or a intrinsic sphincter deficiency.
That's very good. Thank you for clarifying. And then, so somebody is asking if you have tried Urolon for stress incontinence, because,
very shortly. Thank you for asking. Yeah, no, I'm interested. It's very, very new for the UK. I know other places have used it. So yeah, it sounds very interesting and certainly something that we are going to look into using. I think that is something we are certainly interested in as in order to offer all the options for our patient. I think it's important. We don't just offer one.
Indeed. And also the surgeon who has asked this question happens to be a gynecologist. And to the question regarding the cystoscope and hysteroscope and endometrium, he mentions that he has used this with no safety issues.
Perfect.
So thank you very much for clarifying. I'm sure our audience will appreciate this very much. Okay, and then somebody is also asking if attaching suction is also possible instead of a syringe.
Yeah, absolutely. So it's just a normal Lua lock. So any suction, if you have a suction outpatient, that's great. Plug it in and get it sucked out. It's lovely because it's rigid. You can really control it like a little Hoover. It's much easier than a flexi where you do have to do a little bit of maneuvering itself. The nice thing is that the reason I said a syringe in my case is because we don't have suction in our outpatient rooms. It is quite technical. So the whole point is, you could be in any small outpatient room in a small, tiny peripheral clinic. You can use it. But if you do have wall suction, yeah, plug it in. It will suck it out really, really nicely. Certainly a lot easier than aspirating with your other hand.
Yeah, the only thing I will say for hysteroscopy, I know our instructions for use recommend a pressure, intrauterine pressure of around 80 millimeters of mercury. So I suppose with the wall suction, it's a little bit more difficult to control the pressure.
Yeah, I mean, the whole point of suction is just to bring out the debris. We're not using it to, collapse a bladder.
So not permanently then, just a little bit. So, okay, perfect.
Exactly.
Wonderful. Thank you for clarifying. That's great. And then, okay, so we have a question about the other possible complications that can occur after the application of Botox in addition to urinary infection, and how do you treat those complications?
Yeah, so obviously everyone worries about retention, but that's part and parcel of being very careful with the counseling. We don't usually see retention in women. In general, people even with abdominal straining can void out enough. But we have the setup that if they go into retention, we bring them in to teach them how to do ISC until the Botox wears off to an extent where they can void spontaneously again. And I think by doing ISC, they can monitor how much the residual is, and as it naturally goes down, they can then stop the ISC themselves, the intermittent self-catheterization.
Very good. Thank you for explaining. And then I think this is our final question, actually. How do you see the advantage of the Alina Operascope compared to a flexible cystoscope for this procedure?
Yeah, I think, for those who on the audience who's tried doing Botox with a flexible scope, very well it is very fiddly. You can't inject in certain areas because the deflection is affected by the needle. So you can really only inject in certain areas, and it is a two-person job. You need someone there to inject for you. So the whole idea of this is that it brings it all in-house in one. You do it all yourself. You don't need a separate screen. If you want to, keep it in the back of your car so you can go to a different clinic and very easily bring it out. The whole point is it just makes the whole thing easier. It's an easier procedure to do, much more tolerable, I think, as a result, because it's faster. And actually the outcomes are very good, and it's very, very safe.
Wonderful. Thank you very much, Dr. Young. So I see that we have no more questions. I think if you wanted to add anything to your presentation or to your data, you're more than welcome to do so.
No, but I think, thank you very much. And obviously more than happy to take any further questions offline if you just want to drop it to Leader Med, and they'll pass it to me.
Yes, please. If you do have questions regarding the data presenting tonight or the device itself, then please reach out to us, and we'll definitely make sure to put you in touch with Dr. Young. Thank you so much for joining us this evening. And thank you, Dr. Yang, for presenting this wonderful and valuable set of data.